DKA can be deadly. It is caused by a profound deficiency of insulin. These are the symptoms: hyperglycemia, ketosis, acidosis, and dehydration. Precipitating factors, more of the same: illness, stress, infection. They're not taking enough insulin. Maybe they're undiagnosed and this is their first presentation in DKA. Also lack of education or understanding, and then sometimes just neglect. They just don't want to fight this battle anymore. So ketoacidosis occurs when we have so much sugar on board, but we don't have the conduit or the insulin to get into the cell, and that is our fuel source. So the body will break down our muscles and break down fat, and fat metabolism, the byproduct of that is acidic ketones. The ketones get excreted in the urine. They also get some pretty profound electrolyte imbalances with that. Again, hyperglycemia causes osmotic diuresis, so they're going to have polyuria. They're going to be dumping a lot of urine, and without any kind of fluid resuscitation, they're going to get dehydrated. They're going to have severe electrolyte imbalances and that acidosis. You can read that. So clinical signs of dehydration, not any different for anybody else. They're going to have poor skin turgor. They're going to have dry mucous membranes. They're going to be hypotensive. They're going to be tachycardic. They're going to have low urine output because the body is trying to save all the fluid that it can. Early signs are lethargy and weakness when the patient is progressing to DKA. As the dehydration progresses, you see these symptoms. Again, with DKA, abdominal pain is very common. There's a lot of nausea and vomiting. Kussmaul respirations are rapid and deep respirations. The body is trying to correct the acidosis by using the respiratory system to get rid of all of this excess carbon dioxide. They also, not always, but they can have fruity breath, odor. That's from acetones, which relates to the ketones. Blood sugar greater than 250. Again, as I said today, it's all individualized for people. You can be in DKA at 250. It might take you to 1250 to get into DKA. Doesn't matter. We have to look at the symptoms, what the patient is showing us. They will typically have a blood pH lower than 7.3, so that's going to be an arterial blood gas. Also, a serum bicarbonate level is less than 16, and they're going to be spilling ketones in their urine, and also we're going to see that in their serum blood tests. So if we're looking at the Rome method, R-O-M-E, respiratory is opposite, M-E is metabolic is equal. So let's say we have a pH of 7.30, we have a PaCO2 of 30, and we have a bicarb of, let's say, 15. So if we look at that and we use the arrows, we write that pH 7.30, that's a down arrow. PaCO2 of 30, normal is 35 to 45, so that's another down arrow. So we have two things, the pH and the PaCO2, that are going in the same direction. Also, the bicarb, or the base, is less than 22 to 28, which is normal. So that's also going down. So metabolic is all equal. Everything is equally going down. Patients in DKA are in metabolic acidosis. DKA can be treated as an outpatient. Every case that I've seen has been pretty severe, but it can be done with, proper education, fluid balance, medications to stop nausea and vomiting, all of those things. Emergency management, this is what we're going to see in the hospital. We need to make sure that the patient has a good airway If they need oxygen, even if they're 93%, we might want to put a little oxygen on them. It's comforting to them. It shows them that we're doing something, we're treating them. You just don't want to get crazy with that. Just put a little 2 or 3 liters of oxygen on them. Of course, we're going to start large bore IVs. We're looking at 16 gauge, 18 gauge, because we really got to pump the fluid in these people to reverse that fluid volume deficit that they have. So most commonly, I know half normal saline is listed first. Most of the time, fluid resuscitation is going to be 0.9% or normal saline. Can be lactated ringers, but for diabetics, we're typically going to stick with the normal saline. And they may get in the volume, and it may be a very high rate. They may get, 999 for a bag, 999 for another bag. They may get 3 liters of fluid. So we're going to monitor their urine output. So if they're doing 30 to 60 milliliters an hour, that's a good sign that we're doing okay with our rehydration. Now, we don't want to rehydrate them too quickly because we need to protect them from cerebral edema, fluid volume overload. So cerebral edema is actually more related to correcting that serum glucose level too quickly. We cannot do that. We don't want to correct them really anything more than the book recommends 36 to 54 milligrams per deciliter per hour. So if your patient's on an insulin drip, which is very common, you want to make sure if their blood sugar has dropped more than 50 or 100 in an hour, you've got to back off on that insulin drip because you are overcompensating, and that causes a severe metabolic shift, causes sodium and water to flood the brain, and the patient will have cerebral edema, and they may have a traumatic brain injury from that. They may go into a coma, they may herniate, and most likely they will die. So other things, as the glucose enters the cell, as we've got the insulin on board, we're trying to correct that sugar. Sodium and potassium also shift, and that causes a decrease in the vascular volume. And water follows sodium, so as sodium shifts back, the water from the vessel and the vascular volume is going to follow that back into the cell. Also, so they're at risk for dehydration, fluid volume deficit, and hypokalemia. We also need to protect the kidney from an acute injury. The dehydration from DKA, that in and of itself can cause an acute kidney injury, which is easily correctable with giving them volume. But as we give them volume, if their heart is weak, we could cause problems with that. So it's a very fine line we have to walk between, we need to hydrate this person so they don't get fluid volume deficit and have a kidney injury, but we don't want to also injure their heart because they've had all this fluid resuscitation and it's too much for the heart. They will get a BMP and monitor BMPs at least every 2 hours, that basal metabolic profile. Basal? Yeah. Basic, not basal. Basic metabolic profile. So we need to know what our electrolytes are before we start, because as we replace that potassium before the insulin therapy, that's going to drive the potassium into the cells. That's what's going to cause hypokalemia, which can cause some really significant cardiac arrhythmias. As I said, patients in DKA are going to get an insulin drip. The most common recipe for an insulin drip is going to be correction of, usually they're very simple. They are 100 units of insulin, regular insulin, in a 100 milliliter bag of saline. So it's a 1-to-1. So, but it also can be based on kilograms per hour. So 0.1 units of insulin per kilogram per hour. And that you're going to be checking blood sugars every hour, sometimes every 30 minutes when your patient is on an insulin drip, because you can go from 250 to 75 to 40 very quickly. Can't mess around with insulin drips at all. Okay, the next one is type 1s do not go into HHS. This is a type 2 thing. It is a very life-threatening syndrome, and it is less common than DKA. But what happens, usually people over 60, they still can make enough insulin, but they will still present with severe hyperglycemia, osmotic diuresis, and ECF depletion. Those are their symptoms. Common causes, same old story. Infection, illness, most commonly UTIs, pneumonia, septicemia. They may have a very acute illness. They may have just had a surgery and they've had a stress to their body. Just like the DKA patient, it could present for the first time and they're just now diagnosed with type 2 diabetes. Or if they have a history of inadequate fluid intake, maybe their thirst sensation is impaired. That does happen a lot in the elderly. They don't realize they're thirsty until they're severely dehydrated, or they're unable to replace those fluids. And this again, the pathophysiology. They do have enough circulating insulin to prevent the ketoacidosis, but they present with symptoms of hyperosmolar, hyperglycemic syndrome. Some of these are very, very severe and will actually look like stroke symptoms, so we have to be careful of that. They do not have ketones and or minimal blood and urine. This is a medical emergency, very high mortality rate. Therapy is similar to DKA. We're going to do some fluid resuscitation because if your patient is hyperosmolar, we have a serum osmolality level that sometimes is drawn when they're looking to see a ballpark of how the patient's hydration is. We always said if you're high, you're dry. So if your serum osmolality is higher than normal, then your patient is in fluid volume deficit. If your serum osmolality is below normal limits, then your patient is likely in a fluid volume overload or excess. So with hyperosmolar, hyperglycemic, we know they're losing that fluid from their polyuria. So we also need to fluid resuscitate them. We need to give them IV insulin because their blood sugars are off the chain. They are typically 1,000, 1,800, 1,600. It just depends. And also, I didn't say this about the DKA with the insulin drip, but once your blood sugar levels for either one get to be 250, we will add some dextrose to their IV fluids because we want to protect them from having a really significant fall in their blood sugar and then going from super hyperglycemia to super hypoglycemia. They need more fluid replacement than a DKA because they are so dry and so dehydrated, and we have to seriously watch the electrolytes as with the other, looking for those signs and symptoms of dehydration, looking for signs and symptoms that we're rehydrating them successfully, 30 to 60 milliliters of urine an hour. And of course, just like DKA, we're going to correct the underlying precipitating cause. So nursing management, of course, we're going to monitor their blood sugars, look for check their urine output, making sure their kidneys are functioning, giving that IV fluids, starting insulin therapy, monitoring those electrolytes, watching for those signs and symptoms of electrolyte imbalance. We may not always have a lab to rely on, so we need to be aware of what kind of symptoms our patient is going to show us that their electrolytes are out of whack. Assessing renal status, of course, that's, if we have labs, that's going to be serum, BUN, and creatinine, but we're also going to be, of course, watching for urine output. Minimum urine output for anybody, most everybody, is 30 milliliters an hour. So you need to be mindful and watch that. Watching their cardiac status, making sure they're not getting fluid volume overloaded or fluid volume excess or deficit, and watching their LOC because some of those electrolytes, such as sodium and that, as well as serum osmolality, can really cause some neurologic symptoms in those people.